I invite our first chairperson, Dr. Sadish Kumar Kamalanathan. Yeah. He's a professor of endocrinology, JIPMER Pondicherry. He's a known person in the end of endocrinology. Current affiliations, as I told you, is a professor in the JIPMER. He started the endocrinology department in the JIPMER 2010. He has around 95 index publications and 8 book chapters. Next, I invite Dr. Amartya Shankar Chaudhary. He is an endocrinologist, came from Government Medical College. Presently, he is attached to the consultant endocrinologist, the Mission Hospital, Durgapur. My next chairperson is Dr. Rakesh Kumar, the assistant professor in the IQ City Medical College, Durgapur. Is practicing diabetes in the Durgapur and the surrounding South Bengal area. With this, I hand over the mic to Dr. Amartya Shankar Chaudhary to start the proceedings. Thank you. Thank you, sir.
Thank you, Dr. Amitabh Biswas. And with this, I extend my warm welcome to all those who have joined for today's conference, BDCon, 6 BDCon we are having. So I'd like to welcome the chairperson. I'd like to welcome the first speaker for today's session. We have Dr. Satyam Chakravarti, my dear friend Satyam from Kolkata. He's a dynamic endocrinologist and a very prolific speaker. So he'll be speaking on glycemic variability and important consideration in the diabetes management. We all know it's very important predictor of the long-term complications of diabetes. So he'll be speaking on the glycemic variability. Without wasting much further time, I would like to request Dr. Satyam to start his talk. Dr. Satyam, please.
So good evening, everybody. First of all, I would like to convey that I am extremely grateful that I have been invited in such an august podium with people of the stature of my teachers as moderators and my very good friend Amurto as the chairperson. So I hope my slides are visible. I hope my slides are visible.
Yes, yes, Satyam, your slides are visible. Yes.
And they are moving?
Yes, they are moving.
Okay. So good evening, everybody. I start with an index case, and here I show a 53-year-old, 78 kgs, BMI 34 female advocate, diabetic for the last 19 years, with peripheral neuropathy with normal renal function. She is on premixed insulin, 54 before breakfast and 38 before dinner, along with metformin 2 grams. She explains that her fasting plasma glucose levels vary between 66 to 300 and the postprandials between 15 to 400. She experienced 3 hypoglycemic episodes in the last 2 months with an HbA1c of 9.4. Worth mentioning, there were 2 episodes of hospitalization where the lab blood glucose came to be as low as 15. So with this on the background, we start today's discussion on glycemic variability, and we will find out whether it is an important consideration in diabetes management. So basically, we have been harping on HbA1c monitoring, and we have to understand that glycemic control is one of the main treatment goals for type 2 diabetes, although there of late there has been a lot of pleiotropic effects which is coming into the purview. Now HbA1c has long been the gold standard for assessing glycemic control, but we have to take into account that HbA1c does not take into account fluctuations in blood glucose levels. Now, what are the consequences of these fluctuations? We have to understand that there is an increased risk of hypoglycemia and there are glycemic excursions. Now, as evidence suggests, these in totality increase the risk of micro and macrovascular complications and also has an impact on psychological well-being and the quality of life, issues which are less often addressed in our day-to-day diabetes practice. So the concept of glycemic variability has recently emerged as another measure of glycemic control, which might constitute an additive to HbA1c to discern diabetic complications. Now, basically, there is defined as the measurement of fluctuation of glucose and other related parameters of glucose homeostasis over a given interval of time. So there may be short-term glycemic variability and there may be a long-term glycemic variability. The short-term means the glycemic fluctuations within the day or between days, whereas the long-term is the glycemic variability over months to years. And we have seen that we now have accumulated enough evidence from the advanced devote empiric studies where it has been found that the long-term glycemic variability is well correlated with an increased risk of both microvascular and macrovascular complications. So if you see the basic metrics for assessment of glycemic variability, so for long-term glycemic variability, it is more or less easy for the HbA1c fasting blood plasma glucose and the postprandial plasma glucose. But when it comes to the short-term glycemic variability, we have to understand that it's a bit difficult and we have to use certain metrics to find them out. That, for example, the standard deviation, the coefficient of variation, the magnitude of variability, the mean differences between the peaks to nadirs, the conga, and the absolute difference between sequential readings divided by the time between the first and last blood glucose measurements. There are multiple others. I will not go into the details because we have some much more interesting things to discuss. Now, if we see the effects of glycemic variability on adverse clinical outcomes, we have to understand that once there is profuse glycemic variability, even if the HbA1c is under control, not only there will be increased risk of hypoglycemia, but also microvascular complications and cardiovascular complications. Among the microvascular complications, for reasons unknown, maybe diabetic neuropathy is leading the microvascular complications because patients with increased amount of glycemic variability have much more evidence of diabetic peripheral neuropathy. Now, again, glycemic variability is an independent predictor of hypoglycemia, and we understand that higher glycemic variability doubles the occurrence of hypoglycemic events. And when there is hypoglycemic events which are clinically significant, there will be more of sympathetic outbursts, there will be cascading of events, there will be systolic hypertension, sudden abrupt rise in the blood pressure, sudden positive chronotrophy in the myocardial architecture, which will in turn increase the myocardial oxygen demand. And finally, if the myocardium is already ischemic, there is a chance of developing an acute myocardial infarction, or because of the systolic increase in the blood pressure, there is always a chance of developing a cerebrovascular accident. So if you look into the various pathophysiological mechanisms of glycemic variability and microvascular complications, basically these are the basic, the slide might look a bit busy, but it is basically the oxidative stress which leads to epigenetic changes. Basically, it is not the genetic, but it is the epigenetic, like demethylation changes, which ultimately lead to endothelial dysfunction. And if you go into the intricate details, so there are increased transcription and persistent vascular dysfunction and total endothelial remodeling, which will not only increase the arterial stiffness at places, but also render the total endothelial architecture more susceptible to atherosclerosis, accelerated atherosclerosis, rupture of the atherosclerotic plaques, and sudden cardiac events. So if we see that the glycemic variability and the cardiovascular health, there are certain avenues which are being altered by the huge amount of glycemic variability in certain patients of diabetes. And we all know now that glycemic variability is an independent predictor of the cardiovascular mortality in type 2 diabetes patients, which has been proved beyond doubt in a number of studies. Now, let's keep aside all the scientific architecture, all the scientific reports which I was just thinking, and let's think beyond medications for a bit. I know we are all scientific personalities and we'd like to speak science, but let's see, are the pharmacological agents enough to control this glycemic variability? And I am coming back to the index case. And what we find here, we find that the patient was using a premixed insulin 54 units before breakfast and 38 units before dinner. And there was severe glycemic surges and severe hypoglycemic events, notwithstanding the fact that the HbA1c was still hovering around 9.4. So we know that the patient was in a misery. Now, if we see the large dose premix which is being administered to the patient, and you will understand that if you see the basic insulin pharmacokinetics, the larger single dose you give, the more unpredictable becomes the absorption and the more increase in the glycemic variability. And if we split the large doses into halves, what we find that there will be increased absorption and much more predictable absorption by the insulin divided into multiple minute depots and partly by being placed close to highly perfused layer of the skin and subcutaneous tissue. Now coming to the second point, this is what is my experience when I examine the injection sites of my patients of diabetes who are on long-term insulin administration. And the right in the top end, right top end corner is the patient index patient about whom we are talking. Now, is it not apt to check the injection sites? And do we speculate that we can curb away glycemic variability if the patient is not educated about the proper technique of insulin injection? Because evidence suggests otherwise. There are a lot of papers which say that the lipohypertrophic tissue injection use is associated not only with higher dose of insulin and non-optimal glycemic control, but more important is the second point. And what does it suggest? That there is potentially adverse clinical outcome with insulin injections. Someone wants to come in? With insulin injection into lipohypertrophic tissue, which might not only due to the impairment in insulin absorption and action, but also because of the which ultimately leads to erratic and unpredictable blood glucose concentration, impeding insulin titration. So that's the point. And is it not, when we are discussing glycemic variability, we need to discuss the proper, educate the patient about the proper use of insulin and the proper means to inject insulin. Now let's again come out of the scientific arena and let's go into mythology. And I hope this nobleman does not need any introduction. By the way, what happened is that this nobleman said something very peculiar. Spirituality cannot take place on an empty stomach. God knows the books we used to study in physiology, the Ganong Gaiton were written much ahead of his times or not. I don't know how he came to know about the intrinsic mechanism of the metabolic expenditure of the body, which is basically guided by the lateral hypothalamus, the hunger center, and the ventromedial hypothalamic nucleus. And the intrinsic programming suggests that we should take intermittent feeding in order to keep the system intact at 3 to 4 hourly interval. Maybe diabetic patient or a non-diabetic patient. Because if we keep ourselves empty for a long time, It is only the ghrelins and the neuropeptide Y which will stimulate the lateral hypothalamus, the hunger center, and with a suppression of the leptins, there will be an emotion. And I presume that emotion is not of spirituality, but a lust for having more and more food. So, having said that, if for the timing, I presume that the Almighty was the one responsible for our creation, and He is the one who framed this intrinsic programming of the hypothalamic architecture, how are we justifying few types of nonsense, and are we not justifying binge eating in the name of the same Almighty? And what happens to the diabetic patient when they indulge in such harmful activities? Are they not increasing the glycemic variability? I think it's time to ponder upon these few facts. So what are we doing? In fact, just remember the long periods of fasting and what we have in the glycemic profile. And finally, in the evening, just recollect the type of food hello, and just recollect the type of food which are being offered in the evening after the fast breaks. Up, and above, sometimes out of the world. Okay. Another confusion. Morning walk. After an overnight fast, we usually sometimes ask our patients to go on a morning walk. We don't ask, the patients themselves go for a morning walk sometimes. Now, I went into the literature and I find out the patterns of hypoglycemia in hospitalized and non-hospitalized patients with diabetes. And I wanted to find out the circadian variation of all types of cardiovascular and cerebrovascular accidents. And I hope all of us know that nocturnal hypoglycemias are much more common. But what is more important, as far as glycemic variability is concerned, the time period when most of the number of hypoglycemic events occur at all. And if I correlate with the second study, the timing of the cerebrovascular and cardiovascular events, don't they coincide? And don't they have any relation as far as glycemic variability is concerned? So basically, I am a confused man. I am confused because I am yet to find a literature to study that morning walk has any extra celestial advantage over walking at any time of the day. I was just moving inside my hospital, and I presume it is not my hospital. It can be in any hospitals of the country of Bengal. And I was just crawling into while walking, and I found a beautiful publication where they tried to find out whether increased glycemic variability was independently associated with length of stay and mortality in non-critically ill hospitalized patients. And what we know for sure, hypoglycemia is one of the factors which increases the length of stay, not only, but also the mortality in ill patients, hospitalized patients. But much more important, what they found is the standard deviation of glucose and the coefficient of variation of glucose, which also had very high significance, and glycemic variability as far as the length of stay and mortality of patients critically or non-critically ill are concerned. And then I move inside the hospital and I find this prescription. I hope more often than not, all of my respected colleagues do find this prescription. And what are we addressing? Are we addressing glycemic variability in that manner? And what we aim to achieve? If we try to catch the horse from behind by holding on the tail, this is what we are going to receive in reply. And when you try to catch the horse, this is the way, I presume. And you can well find the amount of glycemic variability which sliding scale bestows. And when we change into the basal bolus insulin regimen, this is the status of the glycemic variability. So Just talking about glycemic variability is not enough. If we only talk about glycemic variability and do not implement it in our day-to-day practice, the discussion on glycemic variability will only remain a pharmaceutical propaganda unless we each of us promise today to educate our junior colleagues and also sometimes ourselves that to refrain from using the sliding scale regimen. And after everything, if nothing is addressed, we always now have the CGMS, but it comes at a cost. But when we are using CGMS, I presume that the patient has to keep all the intricate details of what the patient is taking along with the time. Otherwise, it makes no sense. We will not find out what is causing the problem, what is causing the basic variability. So coming to the thing which is often discussed, effect of anti-diabetic drugs on glycemic variability. This is the evidence which we have all find that the DPP-4 inhibitors have robust reduction in glycemic variability. Now the GLP-1 receptor agonists have also shown, and there is good evidence that DPP-4 inhibitors have reduced glycemic variability as far as the pancreatic beta cell dysfunction is concerned, and they have been considered an effective therapy for reducing glycemic variability. And this is what we have evidence. And what I found is that being unbiased, basal insulin with GLP-1 receptor combination has brought down glycemic variability. DPP-4 inhibitors combined with metformin again do address glycemic variability. And one of the study concluded that metformin plus vildagliptin vis-a-vis metformin alone can also address glycemic variability. So to conclude, I should just say that it is an important matrix to consider, but only pharmaceutical intervention may not be enough to address the glycemic variability. So improved treatment adherence and better management of type 2 diabetes will, as far as glycemic variability is concerned, will lower risk of long-term micro and macrovascular complications, improve quality of life, and also render treatment satisfaction. So I like to rest my case on that note.